Welcome everyone. This is Dr. Jaitly, your cardiologist, on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and its illnesses, as well as spreading the word across the globe regarding how we can combine the patient education to clinical education, which the doctors automatically get through their CMEs, but the patients, the general masses, need to be updated and brought to speed. So the whole idea is through this initiative that I've been able to offer in the past 35 to 40 years, and now in this format of my video teaching, is primarily to encourage increasingly more general masses to understand that the patient education is as important as the continued medical education that the medical fraternity normally receives. Remember, this is education material only, should not be taken as medical advice, and should you be having an emergency, of course, go and see the nearest hospital, go call for an ambulance, or go and see your own doctor. Okay, so having done our housekeeping here, let's get back to the teaching mode here, and that is primarily today we are going to be talking about what is SVC syndrome, and that's the subject of choice today. Again, and through our video formats, in our video vignettes, we try to discuss small little things which really prepares our interns, the fellows, and the residents, and of course exam-going students, I always call them, who are about to take their exams, or even during the day-to-day activities, their rounds, etc., or tutorials, they have to go for the evening rounds, etc., so they can catch up quickly and understand more so. So it's primarily an education material that's being offered for the medical fraternity, and of course the general masses certainly can follow our general mass video formats, which I have all compiled through this library. So without any further ado, SVC syndrome is primarily an obstruction which normally starts over the SVC, as it's called, the superior vena cava area. Now, this being your aorta, as we show here, and of course we're not going to be talking much about the aorta today, we'll be more talking about the SVC, which is actually the major vein that's pouring into the right atrium here, if you will, and this happens to be a right atrium. So what happens is you have an obstruction somewhere here because either of the lymph nodes that are involved, or there is a tumor, or there might be some fibrosis. So those are 2 or 3 major, or granulomatous conditions, for instance, like tuberculosis. So just so that you know, whenever there's an obstruction, either from outside or from within, like a thrombus itself, or sometimes, which we call it is intramural, that develops over because of paraneoplastic syndromes, or even the extension of the thrombus or neoplasia within the thin walls of these superior vena cava structures, that can lead to SVC syndrome. So what have we understood so far? Well, to make it very simple, I just want to say the etiology is either intraluminal, it's my allergies, the fall season has begun. So intraluminal, the other is mural, which is actually within the wall of the SVC, and the third is extramural, if you will. Okay. So intraluminal, primarily we just understood by saying that there might be a thrombus, for instance. A thrombus can develop, say there was a CVP catheter that was placed in, a CVP catheter, or there could be say a pacemaker lead, which was a temporary pacemaker wire, and that pacemaker lead got infected and therefore now collects a thrombus on it. So again, normally they don't cause a complete SVC obstruction, but still, again, an SVC obstruction is an obstruction, and that's what leads to, and we'll talk about the clinical features in a second. But CVP lines, pacemaker lines, Swan-Ganz. Now, Swan-Ganz catheters, they used to be very prevalent in my days when I was a cardiology fellow at Cornell. And this was, we were talking about in mid-80s, but then obviously now with the advent of bedside echoes and Dopplers, etc., Swan-Ganz is almost a forgotten entity right now in the ICU and CCU settings. But however, in the surgical post-op or intra-op certain settings, it is still very, very important. It has an important role for the hemodynamics. So just remember that Swan-Ganz catheters can also get infected and lead to a thrombus formation, and therefore an SVC syndrome can present. More importantly, we should understand, so thrombus was one, the second is neoplasia. Now, neoplasia is a big category, and that should not be forgotten. And out of which there are 3 actually, which are very, very important. One is the small cell lung cancer, I call it SCLC, small cell lung cancer. Now, that constitutes almost about 75% of our cases. The second commonest is lymphoma. Now, there are two types of lymphomas. Obviously, one is the lymphoblastic, so that's the blastic variety, and the other is the large cell. And the large cell lymphoma is also very, very important. But lymphoblastic, both are the culprits here, and they lead to this. And thirdly, do not forget the metastatic disease itself. And the most common metastatic disease that goes to the breast, that goes to the superior vena cava, is the breast CA, the metastatic breasts. So breast cancer tends to metastasize to the superior vena cava area, into these lymph nodes, and these lymph nodes, then they can actually just start obstructing, and there is an extraluminal or extramural obstruction that begins, and therefore the pressures on either side will increase, and the SVC collapses, and the results happen. And those results are basically you are preventing the blood to return back into the right atrium from the head, the neck veins, and of course the upper thorax, including the upper extremities, obviously. So that's what SVC syndrome constitutes. So it is basically an obstruction to the flow into the right atrium from head, neck, veins, upper thorax, and your upper extremities. Okay. Now, understand from the superior vena cava also has, remember, if you recall the anatomy, this is a good test for my students. If you recall the anatomy, there is this is this is called the azygous vein, and the azygous vein tends to drain into the superior vena cava, right in this direction. Now, if you have lymph nodes, for instance, if you have a lymph node obstruction, if you had a lymph node obstruction here above the azygous vein, then the chances are that you'll only have the features of upper body congestion. But if you had the obstruction below the insertion of the azygous vein, the chances are you will have not only the upper body, but also some bit of the upper abdominal area. So now here is your thorax. Okay, I'm drawing a chest. Now imagine this is your chest here. So what is happening is you may start to develop some pleural effusions here. You may start to have in these patients also lung cancers, which are, say, harboring this area of the right side. Now, right side predominantly tends to have more symptoms of SVC syndrome than the left. Remember that. So left cancers of the lung, they tend not to go to the SVC as much as do the right side. Now, breast cancers, of course, either side of the breast cancers can metastasize because they are spreading via lymphatic, and therefore these intrathoracic lymph nodes, especially lining almost the superior vena cava and the azygous veins and the hemiazygous veins, we call them, those veins are actually obstructed. So just remember that there is some collateralization that can develop across the chest, and we'll show the collateralization with this color actually, because these are the veins which tend to develop over the chest, and one can see that as well. Now, what are your clinical features? The clinical features are the following. So having understood what the etiology is, the clinical features are, obviously there'll be some facial edema. That's the first thing that will develop. There'll be swelling, of course, in your arms. So the entire upper body is actually starting to swell. There'll be some cyanosis, which will be mostly in the upper body, and then tend to be engorgement of the veins. So the veins will be very, very prominent, mostly in the facial, neck, as well as in the upper chest regions. Okay, so these are your major features of your SVC syndrome. And then, of course, you do have syncope and palpitations and chest pains and breathing difficulty, which we have not said yet, but we can just include that. Dyspnea and exertion will be present. And these patients, they tend to have more symptoms when they lay down. So when the patient lays down in a supine position, that's when they have more problems than when they are actually sitting up or standing. So this is very, very important. So laying down is actually worse than the sitting up and the standing positions, just so that you know. Now, having understood that, we also need to know that the right atrial pressures, they tend to be higher. The JVD or the jugular venous distensions can be present within the neck veins. And, of course, a chest x-ray, as far as diagnosis is concerned, you can certainly do some procedures. But most importantly, I think you start with a chest x-ray first, which will show either the tumor per se, as I said right here, or pleural effusions. So tumor can be seen, or pleural effusions can be seen. the fluid collections, or sometimes you can only see the widening of the mediastinum. So the mediastinum tends to widen here by the lymph nodes as seen. So here you could see the widening of the mediastinum itself. So that could be seen as well. So a lot of this is actually happening just and it's clearly evident even in the chest X-ray. So the mediastinal widening, and that can occur. Okay, a CT chest is very, very helpful. Obviously, that'll locate the tumor. It'll help locate the tumor. It'll probably stage the tumor. Okay, and then if you cannot find it on CT, then do an enhanced contrast. An enhanced contrast is helpful also, and one can actually locate the level of the SVC obstruction, etc., in those regions, etc. You can do that. So having defined all these things, now then we can also do some invasive procedures like needle biopsies. And needle biopsies, of course, will lead a very, very confirmatory diagnosis. But that's not necessarily until and unless your sputum cytology has been done, and it's not necessary unless and until you've done a bronchoalveolar lavage. And most of the times you'll be able to make a diagnosis non-invasively. And of course, the thoracocentesis. Remember that pleural effusions can be tapped. All you have to do is stick in a needle and right here. And if you stick in a needle right here, it just it gives you the fluid collection, and you can collect the fluid into the bottle here and send it to the microscopic evaluation, and as a result one can really see within the slides what's going on in those patients with examining the cytology. Many times the cultures can be present as well, or bacteria can be isolated as well, because you could have tuberculosis involvement, you could have cancer, of course. Now, I forgot to mention about mediastinal fibrosis that can occur as a result of radiation. So radiation is a very, very important cause as well. So let's include that. RT therapy, for whatever reason, say 5 years, 10 years ago, somebody has received radiations, and that can lead to SVC syndrome even later time. So these are later time SVC syndromes that can develop as a result of fibrosis from radiations also. Okay. Now, many times we end up giving radiations for patients who have SVC syndrome, and that is typical of lymphomas, for instance. And so, it's like a caveat. You want to ascertain that radiation is not the cause of SVC syndrome, but at the same time, also determine if there is a radiation the only way to really treat this SVC syndrome also. So, it requires a lot of clinical astuteness and, decision making on the part of your thoracic surgeons, the radiation oncologists, etc., etc. They'll be all involved. But again, just so that you know, it's for the students, the residents, and fellows that the SVC syndrome is a manifestation of either of cancer, tuberculosis, granulomas, and amongst the cancers, obviously, it's the small cell lung cancer, which is very, very prominent, SCLC we call it. Lymphomas are the next, and breast cancers are amongst the metastatic. They lead the list. And clinical features, as I defined, are clearly facial edema, swelling, and cyanosis, dyspnea, and exertion. There'll be some swallowing difficulty also. So let's include dysphagia as a symptom also, because the esophagus runs right here. And the esophagus runs right there, so that some of these lymph nodes can even obstruct what you may call the esophagus. And as a result, one may have dysphagia. Patients are not able to swallow, and they'll say each time they swallow a bolus, it seems like it's getting stuck. So, in a nutshell, what you've learned is, again, it's not the text of the SVC syndrome that I defined here. It's a supplemental information to your text. I always urge my students, residents, and fellows who are preparing for the exams, etc., please do not take this as the text, but also, supplement your text with the supplements that we offer through our videos on MuniMeterHealth. And that's the whole precise, way of learning, because it's so important that right now, within a matter of 7 to 10 minutes, I like to give you the crux of the educational format in this way. So this way you grasp, and before you go and see a case or two, you will be able to sort of understand exactly what you're dealing with. Okay. Any questions and suggestions and comments, feel free and do write to us, because your opinions are so valued to us, and we really appreciate when you write back to us. And I try to make it a point to write within a short period of time, given the circumstances we are in, with hugely growing crowds and lots of people watching MuniMeterHealth. And of course, we take all the comments very seriously and try to always return our answers. Okay. Thanks so much, and please continue continue to join us on MuniMeterHealth.com on the next video, which is coming up soon, and more exciting stuff. Until then, so long. This is Dr. Jaitly from New York.